Hello world, my name is Dr. Shaham Das. I'm a consultant forensic psychiatrist and I live and work here in London. I assess and rehabilitate mentally disordered offenders, or what the tabloids might call the criminally insane. I regularly assess defendants in courts, in prisons and in special secure psychiatric units that are reserved for the most dangerous and violent patients. Although I specialise in criminal psychiatry, I also have expertise in most aspects of mental health. This video podcast series explores a range of mental health topics. It's for the layperson who might be interested in learning more about severe mental illness. So I'm talking about chronic, lifelong illnesses that hugely impact on the sufferer's functioning, like schizophrenia or bipolar affective disorders. I will analyse how these mental illnesses are in some cases related to offending, and I'll share with you a bit about life from the perspective of a psychiatrist such as myself. This particular podcast episode is about personality disorders. I'm going to tell you what the definition of a personality disorder is and also how it's different from a mental illness. My USP, I think, is my experience from the hundreds of cases that I've assessed over my career. That's 15 years of working as a psychiatric doctor. So for this particular episode, I've handpicked a few cases of patients with a diagnosis of personality disorder. So I've selected antisocial personality disorder and borderline personality disorder because these are the cases that I see most often in my clinical practice. Of the cases that I'll discuss, one of them is a criminal court case that's directly related to offending and aggression. And the other is a civil court case, which tragically, I'm afraid, led to a very serious suicide attempt. So consider this a trigger warning. You've been cautioned. The diagnosis of personality disorder is in itself contentious, I think is fair to say, and it can actually be damaging in some cases. So some people who've been labelled with a personality disorder find it unhelpful and they find it judgmental. So I'm going to meet this controversy head on, and I'm going to challenge the very validity of this diagnosis. And I'm going to answer a cutting question within mental health, which is this: is the diagnosis of a personality disorder actually helpful? So what is a personality disorder? Well, you can't answer that question without first asking, what is personality? Personality is what makes you, you. Your personality describes the characteristic patterns of thinking, feeling, and behaviour that make up who you are. Personality drives how you feel about yourself, about others, and about the world around you. It distinguishes you from everybody else. And personality traits tend to be stable and ingrained. We all recognise personality traits: grumpy, dopey, doc, happy, bashful, sneezy, and sleepy. Okay, sneezy is a bit tenuous as a personality trait, and doc, I don't even know what that means. Most of the factors which shape somebody's personality are genetic or environmental, so I'm talking about nature versus nurture, but it can be a complex mix of the two, a juxtaposition, if you will. Love that word. To give you a simplified example, let's say your natural temperament from your genetic makeup is quite snappy, right? So you could be bullied as a kid, maybe your parents are not particularly supportive, and maybe you grew up around conflict. Now, you could actually use aggression as a defense mechanism and to avoid being the victim, and this might shape your future personality. Alternatively, your natural temperament could be shy. You could be bullied as a kid and maybe your parents weren't that supportive, and maybe you grew up around conflict, but you evade confrontation to avoid being the victim. So you might even become even more introverted, more shy and recluse, and that could travel on to adulthood. So what is a personality disorder? I hear you cry. When a personality is disordered, you can experience difficulties in relating to others. And this is an ongoing, pervasive and problematic as opposed to temporary. And typically it might result in repeated crises at work, turbulent, strained interactions with friends, partners, relatives, everybody. A personality disorder is not a mental illness, okay? Although, confusingly, they can both be classified as mental disorders. So a mental illness is like a chemical imbalance that causes an altered state. However, personality disorders are not external diseases that can, at least theoretically, be treated with medication. So what I'm saying is it doesn't happen to you, it is you. Mental illness, on the other hand, generally kind of fluctuates with remission and relapses. So we talk about periods of mania, periods of depression and psychosis. And a mental illness is different from the baseline you. It's like a change in your mental state. Having said all of that, there are grey areas, and psychiatry is rarely black and white. So some symptoms of mental illness and personality can overlap, making it hard for a psychiatrist to diagnose one or the other. So for example, paranoid personality disorder, which I'll tell you about later, and paranoid delusions, which can occur in psychosis. And then to complicate things even more, they can coexist. So for example, people with borderline personality disorder often have brief periods of psychosis. A common scenario on a forensic psychiatry ward where I work is this. A patient comes in with a psychosis, they're really unwell, they're agitated, possibly hearing voices, and then they're treated with medications, and eventually they settle, and the voices are cured. But then after that, their behaviour can still be quite challenging. They can be argumentative, they can be hostile due to their natural personality, and also due to learnt behaviours from their own harsh upbringings. I'm going to talk about personality disorders that are specifically associated with violence and offending. Now, I do not want to give the impression that all people with personality disorders or psychiatric patients in general are dangerous or that they offend. That's absolutely not true. The vast majority of psychiatric patients do not offend, and the vast majority of offenders do not have a serious mental illness. But I work in forensics, which is the juxtaposition, twice in one episode, too much? The crossroads, let's say the crossroads of mental illness and offending. Now I'll tell you about antisocial personality disorder and a case that I saw once to illustrate this diagnosis. So antisocial personality disorder, also known as dissocial personality disorder, for my American brethren who use DSM classifications rather than ICD-10, tomato. This is a very common diagnosis in forensic psychiatric wards and also in prisons. A significant proportion of defendants who are on trial, who I assess, have this personality disorder. It can be kind of thought of as maybe the younger brother of psychopathy, and there's a big overlap. And maybe in a future podcast, I'll tell you about treating psychopaths and also my experience of actually working for one. Antisocial personality disorder is a mental condition in which you consistently show no regard for right and wrong, and you ignore the rights and feelings of others. If you have this diagnosis, then you tend to antagonize, lie, manipulate, or treat other people harshly or with like a callous indifference. You show no remorse or guilt for your behavior. If you have antisocial personality disorder, you often violate the law, you behave violently or impulsively, and you have problems with drug and alcohol use. You are callous, you're cynical, and you're disrespectful of others. Yet you can also use your charm and wit to manipulate others. And you can actually have quite impressive leadership qualities. Famous people with this diagnosis would include Ted Bundy and Jeffrey Dahmer, who are, let's face it, not a great endorsement for the diagnosis. I'll tell you about a fairly recent case I dealt with, which really sticks in my mind. So I'd like to tell you about the case of Mr. T. He was a long-term unemployed man who was about 42 when I saw him, and I saw him on bail for a court report. His solicitors instructed me, and I saw him at their offices. And Mr. T had beef with the local council housing authority, and around mid-2018 he breached an injunction order, so he was forbidden to go within 20 metres of their office. But one day he stormed in there and he was aggressive towards the receptionist. He was screaming at her, leading her to hit the panic alarm. And when the other members of staff came out to her rescue, Mr. T became aggressive and continued to be verbally abusive. He was swearing, he was insulting, he even used some racist language. And I've actually read the transcripts within the witness statements, which was part of the evidence in the court bundle that I was given. And yep, he was pretty offensive. some of it was even quite creative. You could even say it was poetic. Mr. T had a history of anxiety and depression. And to be honest, I think his solicitors were kind of pushing their luck a little bit. They tried to suggest that Mr. T couldn't understand the legalities of the injunction order because he had problems with his reading and writing. And from their communications with me, the solicitors that is, I think they were kind of pushing me to agree with them. And this does happen sometimes with cases with some, although a minority of solicitors. But the evidence in the court bundle also contained witness statements from the housing authority and the staff there. And to be honest, he was a nightmare resident and a nightmare neighbour. Mr. T apparently had committed a litany of antisocial behaviour spanning many months. And that was playing loud music. There were people constantly going in and out of his flat all hours of the day and night. There was a strong smell of cannabis, and there was suspicions that he was actually a drug dealer. So Mr. T would spend most of his day just sitting on the balcony in this tenement block of flats, and he would wolf whistle female passers-by, and he apparently caused nuisance to other residents by throwing rubbish out of his window. He even threw a plant pot, which is kind of like a funny image in my head, but probably not so much if you were standing directly underneath. So Mr. T had multiple warnings from the council and physical fights with his neighbours, but his behaviour just didn't change. And whenever he was confronted, he would just shout and swear, even at the housing authority staff and at the police. And this is what led to the injunction in the first place. And to be fair, I think Mr. T did genuinely have some mental health issues. He was depressed. He saw his GP. He was prescribed antidepressants and mood stabilizers, although he actually took them quite sporadically and he didn't really attend his follow-up. Mr. T had some previous offending. I saw the evidence in the court bundle that I was sent, and I was given his police national computer record, which showed a range of minor offences, about 84 in total, which is impressive, but to be honest, it's not the most I've ever seen for a defendant. I'll tell you about that in a future podcast. Mr. T's offending was mostly low level. It was mostly drunk and disorderly, car theft, assaults, stuff like that. So not serious violence. When I saw him at his solicitor's office, he turned up 45 minutes late. He was flustered. He just had an argument with somebody who worked at a post office over the payment of a parcel he was sending. When I saw him, there was no apologies or no acknowledgement that he was late. And right off the bat, he was keen to express to me that he was the victim of the post office incident, but more importantly, regarding the whole housing authority incident. And before I'd even asked a single question, Mr. T started ranting about the housing authority staff because, according to him, a number of repairs that should have been done by the council had not been done and they'd been very slow to react. He said that although some of the problems had been sorted out, such as a recent leak, they had not sorted out others, such as dampness in the wall. So Mr. T said that he'd phoned them several times and was either dismissed or ignored, and this made him extremely irate. And to be fair, what he said was probably true. And he wanted to give them a piece of his mind. So when he went down to the office, he said he was very, very angry, but he couldn't remember what had actually happened when he got there. Now, it is quite common for defendants to claim they cannot remember alleged offences. And sometimes it might be true. Other times, I'm pretty sceptical. And to be honest, it's very hard to prove either way. Defendants fabricating mental illness and fabricating memories and symptoms is a topic for a whole other podcast episode, and maybe I'll do that for you in the future. Mr. T said he'd read the witness statements, and so he'd read the accusations of what he supposedly, allegedly said, but he said it wasn't true because he just wouldn't use racist language. And even though his solicitors were instructing me, and ultimately they paid me for the report, as always, my report was authored on behalf of the court, not on behalf of them, not on behalf of Mr. T. So it was neutral, it was objective, and it was honest. And similarly, at times when I'm instructed by the Crown Prosecution Service, my evidence has to be neutral and it has to be for the court only, not to benefit the prosecution. So in this case, I opined that Mr. T probably did have depression, and it was probably related to a number of social factors. He had a turbulent family home. There was lots of drug use in his adolescence. He had issues with his housing, unemployment, financial issues, regular arguments with an old girlfriend. He just had a ton of drama in his life. Also, Of note, there was an incident last year when he was stabbed multiple times, and he says it was a random attack and he was very traumatized. And I have to admit, I did kind of wonder if it was related to his suspected drug dealing, but obviously that would be speculation, so I did not comment on that in my report. I did say, however, that he did not meet the criteria for post-traumatic stress disorder, which I think he was trying to push, because there was no evidence of flashbacks, no avoidance triggers, even though undoubtedly the stabbing would have been traumatic. Post-traumatic stress disorder is another diagnosis I see quite commonly, and I think talking about it and its symptoms is another podcast for the future. But most importantly, in my opinion, Mr. T had antisocial personality disorder, and that was my terminology for him. I'm sure his neighbours would have used perhaps more colourful adjectives for him, perhaps even as poetic as Mr. T's previous tirade. Now, I just want to be clear about something. As an expert witness, my job is never to judge, right? It's irrelevant whether or not I personally like or dislike somebody or what their past has entailed. The majority of the defendants that I see have tragic histories, often full of neglect and abuse, and they're often quite vulnerable. Equally, many have a history of quite horrific offending. Occasionally it includes assaults, domestic violence, sexual offending, even paedophilia. And my job is strictly to guide the court on matters of mental illness as an expert. The judge and the court only should decide about justice and punishment, not me. And if I was to do that, I'd be overstepping a professional line. That doesn't mean I can't have an opinion on the people I see. I just have to keep it to myself. And I should not allow it to cloud my judgment or enter the evidence that I give to court. Now, when I asked Mr. T about the index offence, he told me that he just could not understand this injunction order. And that was basically the basis of his defence. And he said he had a learning disability. But the evidence didn't really reflect this. I mean, Mr. T attended a mainstream school. He had some education. He held down some jobs at times. So if he did have a learning disability, which he probably didn't, then it would be very mild. But one of the most revealing parts of my assessment, my Columbo moment, there's just one thing I don't understand, was this. Mr. T could outline the tenancy agreement and the repair promises that were made to him in detail. So I wasn't really buying that he wasn't capable of understanding the injunction order. Now, I would never call Mr. T a liar in my report because that's too judgmental, but I opined that judging by his general level of functioning, his overall cognitive abilities, and his understanding of other documents and concepts, there was no psychiatric reason that he would not be able to understand the conditions of his injunction order. And therefore, he must have known that he was breaching this by walking into the housing authority office and being abusive, allegedly. I also told the judge that his behaviour might have been connected to some features of his depression and anxiety. So, for example, they might have led to agitation and irritability to a degree, but it's more likely connected to his personality structure, i.e. antisocial personality disorder. Finally, and most importantly, I relayed that in my opinion, there's no psychiatric reason that Mr. T's mental state would have affected his criminal culpability for his actions. If you want to learn more about criminal culpability, I covered that in episode 1. Please check it out. Staying on the topic of antisocial personality disorder, I wanted to tell you guys about how some people with this diagnosis affect the milieu of a psychiatric ward. Also love saying milieu. It's a great word. It's no juxtaposition, but still. So milieu is the social environment. Antisocial personality disorder is common on forensic psychiatric wards, which is unsurprising as the patients have a history of offending and violence to actually be there in the first place. And some patients with antisocial personality disorder, they bully and they take advantage of other patients. It's kind of the same as you would expect in prison, but you could argue that psychiatric patients are often more vulnerable than prisoners. Sometimes antisocial personality disorder patients form gangs and they intimidate, they bully, they commit boundary breaches, for example, smuggling drugs onto the ward, even though patients are searched when they come back from leave, but I guess where there's a will, there's a way. And some antisocial personality disordered patients bring in the prison culture onto psychiatric wards. Many have been in prison for some, if not all, of their adult lives. Not all patients are like this, even on forensic psychiatric ward, And to highlight this, I'm going to tell you very briefly about the opposite end of the spectrum. So I remember a young man once whose index offence was that he killed his cousin. He was floridly psychotic at the time, and he thought the victim was an imposter. He was actually suffering from Capgras syndrome, which is a delusion that I specifically mentioned in episode 3. Go check it out. So this man strangled his cousin in his sleep. And when he came to our ward, he was very confused. He was disorientated for several months whilst he was psychotic. And after he'd been treated, he turned out to be a really nice, polite young man. He was timid, he was shy. And I just remember feeling there was this like disconnection between him and his index offence, what he had done. And it was really hard to believe they'd committed such an egregious act. And he never lost his temper, never argued with staff, never came back late from leave. And despite a drugs epidemic going on the ward at that time, his urine drug screens were negative. The drugs epidemic is another issue I can talk to you about another time. As a psych note, an anomaly that I've noticed in my career is that people with antisocial personality disorder tend to thrive in prison. I think it's because they're kind of enmeshed in the criminal underworld, and they have their criminal peers there, they have their mates there, there's like a structured hierarchy of criminals, there's drugs there. Whereas people with antisocial personality disorders don't necessarily fare that well in psychiatric units. And in fact, they're actually quite shocked when they get there, because they assumed it would be easier and more comfortable than prison. But in actuality, they're around very unwell people, some of whom struggle to meaningfully interact with them. And they're probably observed more actually by nursing staff than they would be by prison officers, so they have less freedom. And they often feel like they don't belong there. And I've even had a few patients in my career who asked me actively to transfer them back to prison. Okay, now I'm going to change topics and I'm going to get slightly philosophical. I'm going to consider a question which is slightly contentious, which is this: can the labelling of personality disorder actually turn out to be harmful? As a psychiatrist, and even as a person, I think it's important to keep an open mind, but also to always question things. Yeah. So not to accept everything at face value, and to recognise the flaws in our system and also to challenge them. I question the validity of a diagnosis such as antisocial personality disorder. Not the individual features, because there are definitely people who meet the criteria, but the concept as a whole. And I think there's a compelling argument that psychiatrists are simply medicalising criminal behaviour by diagnosing antisocial personality disorder in the first place. Because if you set the parameters of a disorder as being violent and immoral by default, then of course making this diagnosis in a population of people who are renowned for being, well, generally violent and immoral by default, then you're kind of creating the situation, if you see what I mean. It's like a diagnostic chicken and egg. A psychiatrist labelling criminality as a mental disorder, or did this set of character flaws cause criminality, which we are now diagnosing? I also sometimes wonder if the diagnosis of any personality disorder is helpful, because labelling can be damaging. Patients with personality disorders are sometimes seen as troublemakers, and I've seen stigma within mental health staff, and these are the people that are supposed to be treating patients, let alone members of the public having stigma. Dozens of times in my career, I've heard staff say, "Oh, he's just PD." For example, if someone's like self-harms on the ward because they didn't get their leave. And I take this to mean that it's just behavioural and it's just for attention. And reading between the lines, sometimes I feel that the staff are saying that the patient is in control of their actions and that their behaviour is intentional and it's manipulative, as opposed to the patient has a mental illness and therefore cannot be held responsible for their actions. However, on the other hand, I've also seen cases where the diagnosis of personality disorder actually turns out to be helpful. So I remember diagnosing a young woman with borderline personality disorder who repeatedly would deliberate self-harm. She would burn herself with cigarettes, she would pull out her hair, and she had a really difficult relationship with her mother. She was constantly getting kicked out of the house. And when she was diagnosed, she was grateful for somebody to put a label on it. For her, it was reassuring that it was a common disorder and it wasn't severe mental illness. So to her, it was comforting that what she had was like a recognizable entity with a name, because in her mind, it wasn't something more serious like manic depression, which is the older term for bipolar affective disorder, which her uncle had. And it also meant that she was happy because she didn't have to take medication for the rest of her life. So I've just recently mentioned borderline personality disorder. That's another very common personality disorder I see. It's also known as emotionally unstable personality disorder for our American brothers across the pond. Again, tomato, tomato. And I think there's a misconception, because the phrase borderline personality disorder doesn't mean borderline as in just about. That's absolutely not true, because it can be a very severe disorder. Initially, it was suggested that borderline disorder bordered on or overlapped with schizophrenia as a diagnosis. So the features of this are unstable moods, behaviours, unstable relationships. It usually entails a fear of abandonment. It usually entails unstable relationships and impulsive or self-damaging behaviours. For example, this might include excessive spending, unsafe sex, deliberate self-harm, substance misuse, reckless driving, binge eating. And a characteristic feature is a varied or random mood swings, as are anger issues, including frequent arguments and frequent fighting. And what I'm about to say is a huge generalization, but very broadly speaking, within the world of forensic psychiatry at least, people with borderline personality disorder are not usually career criminals. They don't commit sort of premeditated offences as part of their active lifestyle, although this does happen with antisocial personality disorder. In fact, people with borderline personality disorder act out impulsively and sometimes violently because they struggle to contain their own emotions. So they're not like intentional offenders. They face drama like we all do, but for them it just kind of spirals or it escalates, and the police are sometimes called. So I'm about to tell you about a borderline personality disorder case of mine that I had. And this case really stuck in my mind because the patient, Miss B, had almost all the features of borderline personality disorder, which I just listed for you. So, as I've said before, as well as criminal court cases, I act as an expert witness in civil court cases. And this particular case, Miss B, was a clinical negligence case, because it was alleged that she was discharged from hospital prematurely and not supported properly. Her community mental health team didn't review her even when she asked for help. And tragically, what happened is that she jumped off a balcony on a second floor and had severe injuries. She broke both of her femurs. Now, I'm not going to talk about the clinical negligence aspects of this case in detail, only because it's so complex and there's so many factors that there's just not enough time to do it justice. But perhaps I will talk about a similar case once again in a future podcast. But one thing that particularly springs to mind is a similar case of this where I had to give evidence in a coroner's court. So a man was picked up by police on the motorway and he jumped in front of a lorry. He then was taken to hospital and he had a mental health act assessment, and he was not sectioned, he was released, and he went on to immediately go back to the same motorway, and tragically he killed himself. But that's another story for another podcast. Back onto Miss B. So as I said, she had a history of suicide attempts. She really had unstable moods, and that was illustrated by her constantly seeing a GP, asking for a change in antidepressant medications, then not taking them, saying she felt better. She had very turbulent behaviour and turbulent relationships. I mentioned before, she was constantly falling out with her mother. And even on the ward, she had arguments with staff and other patients regularly. And she also had issues with her boyfriend, and there were suspicions of abuse, and she made some allegations, but then she later withdrew them. So in terms of the diagnostic features of borderline personality disorder, Miss B demonstrated a fear of abandonment because she stayed in abusive and controlling and toxic relationships, and not only with a boyfriend, but also affiliated with a drugs gang who seemed to exploit her. She also had self-damaging behaviours, not only suicide attempts and deliberate self-harm, but also things like substance abuse. I wouldn't say she was an addict, but she would go on coke and alcohol binges, and she would end up arguing with a family or a boyfriend, smashing the place up and getting arrested. But also I think she had like more subtle, indirect forms of deliberate self-harm. So for example, she would sometimes sabotage her own treatment, and she would stop taking medication even though they were clearly helping her. And as a side note, I think it's fair to say that Miss B was a challenging patient for many reasons. And sometimes it seems like she just called for help, including threatening suicide because she was lonely and she just wanted attention. And I think the problem was she cried wolf so often that the community mental health team staff didn't take her seriously. And eventually she called their bluff and jumped off a balcony. Now, it's easy to criticise, and I think that's exactly what her solicitors were asking me to do in the clinical negligence report. Once again, pushy solicitors. But the community mental health team are always stretched. They have hundreds of patients on their caseload, and they have to make a judgment call on who to help. They have to prioritise somebody else who is actually in a mental health crisis. And sometimes they get it wrong. And I'm sad to say, I think it's actually getting harder for community mental health teams and all mental health staff because of ongoing NHS budget cuts, which I'm sure you've heard of. There's less staff now, and there's more caseloads, and there's also a drive for more accountability, which in theory I think is a good thing, but in practice it leads to more and more paperwork and detailed notes because staff have to actually cover themselves. That's a priority now. Ironically, this means there's less time for staff to spend with patients. Incidentally, in this case, I did find a ruling of a breach of duty and clinical negligence, but it wasn't because the CMHT didn't review her on that particular occasion. It was related to something else. It was their generally very poor standard of risk assessments. So I'd like to talk about other types of personality disorders. Some of these don't often lead to offending or even lead to hospital admission, so personally I rarely see them. But other healthcare professionals, psychotherapists, psychologists, people who undertake talking therapies might see them. So here's a few of them. There is obsessive compulsive personality disorder, also known as anancastic personality disorder. And this is characterized by excessive concern with orderliness, perfection, a need to control your environment. And there's a big overlap with OCD. I think the main difference is that OCD is ego-dystonic, which means that the thoughts are unwanted and they're seen as unhealthy and they cause anxiety and they're involuntary. Whereas for obsessive compulsive disorder, the thoughts are ego-syntonic, which means they're perceived by the subject to be irrational and desirable. So it's their personality, and the thoughts of orderliness are their choice, as opposed to OCD, where it's intrusive and unwarranted. Another one is avoidant personality disorder. So this is strong feelings of nervousness and fear. It's associated with poor self-esteem. So people who suffer from this have an intense fear of rejection and being negatively judged by others. So it's a bit like social anxiety, but much, much more intense, and it's kind of ingrained into them. Then there's schizoid personality disorder. So that's a lack of interest in social relationships and a tendency towards a solitary or sheltered lifestyle. And other features of this disorder include secretiveness, like emotional coldness, detachment, and apathy. And they tend to be quite recluse. So it's kind of similar in some ways to autism, which I talked about in episode 1, but schizoid personality disorder doesn't have the other features of autism, like restrictive or repetitive behaviours. Then there is narcissistic personality disorder. So these people are self-centered, they're arrogant in their thinking and their behaviour, they lack empathy and they lack consideration for other people. And they have like this excessive need for admiration. Other people often describe people with narcissistic personality disorder as being like cocky, manipulative, selfish, patronizing, and demanding. Now, I'm sure that must sound familiar to a lot of you. You know, that arrogant guy who you never invite out to the work night outs. And if you're thinking, hang on, we never have work night outs, well, maybe it's you. Then there's histrionic personality disorder, and that is characterized by a pattern of excessive attention-seeking behaviors. So they just need to be the center of attention. And that might include inappropriate seduction and an excessive need for approval. Now, obviously, you'll be able to tell there's a big gap between this and narcissistic personality disorder. The difference is this: people with narcissistic personality disorder always want to look good, whereas people with histrionic personality disorder, they just want the attention, even if it means that they actually look bad. Another difference is that narcissistic personality disorder people don't have empathy. They just do not care about others, whereas with histrionic personality disorder, you can care about others. Then there's paranoid personality disorder, which, as the name suggests, is characterized by extreme sensitivity. So these people cannot forgive insults, even like gentle ribbing, they can't forgive it. And they're often suspicious, often without justification, with a tendency to distort experiences by misconstruing neutral or even friendly actions of others as hostile or contemptuous. They're also probably not going to get invited to the work night out, although if they find out that they weren't invited, then it's not exactly going to help their paranoia, is it? So the next question is, can you treat a personality disorder? The short answer is kind of. As I said before, they are ingrained, and so obviously they're notoriously difficult to treat. And as I said earlier, they're not like a chemical imbalance that you can just theoretically calibrate with medication. No medication can cure a personality disorder, but some can take the edge of associated features of the personality disorders like depression or anxiety. So the mainstay of treatment is talking therapies. And there are a whole range of these. Some of them are kind of fads that appear every few years and they disappear. And some are tried and tested and have withstood the test of time. Cognitive behavioural therapy is well known to resolve a host of issues, including personality disorders. Dialectical behavioural therapy is one of the most well-known therapies for personality disorders. So briefly, what this does is it teaches people how to live in the moment. It helps them develop healthy ways to cope with stress, and it helps them regulate their emotions and therefore improve their relationships. It's usually, although not exclusively, used for borderline personality disorder. But I think it's fair that the subject has to want to change. And for that, they need to have insight and they need to fully accept their diagnosis. And for patients that I've seen, they only sort of reach this full level of insight after years of difficult relationship and repeated life issues, such as problems at work and family, before they finally accept that something needs to change and that something needs to come from inside them. I think they ultimately finally accept that it's not you, it's me. Sometimes patients with personality disorders are admitted to psychiatric hospital for crises. To give you an example, a typical presentation might be somebody with borderline personality disorder who deliberate self-harms or takes an overdose. And this is a contentious issue because putting them in hospital is obviously not a long-term solution because personality disorders can't be cured, particularly in the short term. Some personality disordered patients can disturb the ward, as I said before. Antisocial personality disordered patients can bully or manipulate vulnerable patients. Not always, but I've certainly seen it happen. And also, you could argue that reliance on hospital can become an unhelpful and learned behaviour. So many patients have chaotic lives. They can't cope with the outside world. They have harsh relationships. They have problems with drugs. So they can actually become dependent on psychiatric wards because the wards offer them attention, stability, safety. So for psychiatrists, it's kind of like a balance, really, because obviously you want to support and help people, but you can also de-skill them. So we might actually paradoxically teach patients to take overdoses or to cut themselves in order that they can be admitted. But yet, on the other hand, if somebody with a personality disorder is in genuine crisis, like Miss B, who I mentioned before, if you don't admit them, then something terrible could happen, even suicide. And I've come across this a couple of times in my career. So I think it's fair to say that it's a really difficult call. We psychiatrists have to learn to predict the future to a degree. So we're coming to the end of this episode. I'd be really interested in hearing your views, especially if you or somebody you know has been diagnosed with personality disorder. So please tell me, do you think my depiction is accurate? Or do you have any stories of going through this type of treatment, and did it help? Did being in hospital actually help? So next week's podcast is going to be about drug-induced psychosis. There will be scissors and there will be blood. And I'm going to tell you about a couple of real-life cases I've assessed. One of them led to serious violence. A man stabbed himself in the cheek and then stabbed his cousin. Another case was a little bit more tragic than that. And I'm also going to tell you how drug-induced psychosis is treated. As always, I'm open to suggestions. So if you're listening or if you're watching, and if you have any particular ideas or any particular questions or anything that you'd like me to dissect from the perspective of a psychiatrist and to inform you or other people about, then please hit me up. I'm all ears. So please subscribe to our YouTube channel, follow us on Instagram, and like our Facebook page. And if you want to submit an episode idea or any questions, use our email, which is psychforsoreminds@gmail.com. And if you want to reference us, it's #PsychSore. Until next time, stay euthymic, homies.